Yes.
Thank you, sir. We were looking at, Professor Dillon, at the 2019 Action Plan Achievements and Proposals, and we had just looked at the achievements between 2006 and 2018, and then since 2014. We can see then the heading, the following strategy is proposed with a vision and a why. Then if we turn the page, we pick up how NHS boards, together with local authorities and third sector organisations, and supported by Health Protection Scotland, should treat a minimum of 2,500 people during 2019 to 2020 and 3,000 each year thereafter. It is predicted that this strategy will achieve elimination by 2024. Guided by the recommendations by the SLWG on hepatitis C case finding and access to care, intensify efforts to identify those people undiagnosed and to re-engage diagnosed people not in contact with hepatitis C services, an eclectic model of hepatitis C care, i.e. the provision of services in both hospital and community settings tailored to the needs of the patient, should be adopted. And then there's a point about those who inject drugs. You said earlier, Professor Dillon, that it's a matter for local health boards to deal with this strategy.
Indeed, so each health board has its proportion. Up until 2019, the proportion of the treatment target was by population, and so each health board in proportion to population had to contribute to that total target. So the 2019-2020 target of 2,500 was achieved, but there were some health boards that did better than others, and so Greater Glasgow and Clyde and Tayside were particularly over-delivering in terms of therapy. We don't have the same pharma arrangements as NHS England does, but we did have a capped deal so that as we reached a certain number of patients treated, the drug effectively became free beyond that. So if you over-treated in any 1 year, there wasn't a financial penalty. We didn't get financial rewards for treating more patients, but it didn't cost us any more. And so there was an incentive to try and reach that treatment target so you could then treat patients that you wouldn't have to treat in future years. So the 2,500 was achieved, and then we all know what happened in 2020. The Short Life Working Group did meet and did convene and did finish its recommendations, and so that produced a series of a review of the world literature as to what was the best pathways of care to be used. It highlighted the work done in various parts of Scotland, so what was being done, what was excellence in parts of Scotland was shared. We looked at our English and Welsh colleagues as well to see what they had, and we shamelessly borrowed ideas from them. So that potpourri of ideas of ways of reaching the various risk groups were identified, and each health board could then take what it needed to allow it to achieve its targets. Clearly the bigger urban health boards had a different set of risk factors in terms of injecting drug use being a much more dominant risk factor than in other parts of the country, and so that's why the word eclectic was used.
And can you give us a flavour of the sorts of measures that local health boards have taken in order to identify people? Okay,
and so in terms of diagnosis, so in all addiction centres that are NHS provided, which is the majority model in Scotland, it was a requirement that everyone who was on opiate substitution therapy was tested every year for hepatitis C. Treatment pathways and diagnostic pathways were rolled out into needle exchange facilities, and so using dry blood spot testing to ensure that patients could get easy access to testing. There was ongoing awareness raising amongst general practices around what the risk factors were. There was automated testing of abnormal liver function tests. This was for all liver diseases, but included hepatitis C and hepatitis B testing. This is now standard practice across NHS Tayside and NHS Fife, which accounts for 800,000 people of our 5,100,000 population. NHS Glasgow and NHS Lothian, which are 1.5 million and 800,000 respectively, are about to roll this out. It has been government policy, but clearly the last 2 years have rather held back some of these sorts of developments.
And have there been any general awareness campaigns about hepatitis C run by local health boards?
So there have been, over the years since the action plan started, there have been none since the elimination plan was decided. The individualised treatment targets for each health board, based on, as well as on their population, on their previous performance, were being developed for rollout in the 2020-2021 financial year. All of the staff that were involved in that disease modelling had another disease to model instead, and they have only just come back to hepatitis C work about 6 weeks ago. I'm promised in 2 weeks' time at a meeting that the first tranche of those new numbers will be available to us, and so we'll have some more data at that stage.
And at this point, the elimination programme doesn't have any specific measures addressing the identification of people with hepatitis C infected through blood and blood products. Is that right?
It doesn't, no.
Can you explain for us why that is?
So we looked back through our previous efforts to see if there were any gaps, anything that we couldn't do, that we could do anew in terms of reviewing GP records, in terms of looking at blood transfusion records, in terms of look-back procedures, etc. All of those things have, where they are feasible, have been done already. We looked at our database in terms of, because of Scotland's record linkage abilities, we've captured everyone that's ever had a hepatitis C diagnosis in Scotland, and as of the end of 2020, which is I think the numbers for your statistics, we have diagnosed and treated 460 people who are still resident and alive in Scotland, which is in excess of the proportion of patients from the UK estimates that you would expect. So rather, like Professor Foster has alluded to already, we seem to have found more people than the estimates would suggest that have blood products or blood transfusions as a risk factor, which gives us some confidence that the numbers of patients that could be missed will be relatively small.
What do you see as the barriers in Scotland to identifying any remaining people who have been infected via blood and blood products?
So if we go back through the record, so clearly the patients who have had haemophilia or inherited bleeding disorder are likely to be under ongoing follow-up and will have been in contact with their haemophilia centres or bleeding centres and will have been tested. Those that had random blood transfusions are the more challenging group to find. If we've looked back at the transfusion books that go back into the 1970s and 60s, and these are old-fashioned large ledgers. Most of them contain a date, a name with no date of birth, and a ward on which the patient might have been on at the time that the blood transfusion was requested. We know that the blood left the transfusion laboratory with that patient's name on it. We have no idea if the blood was ever transfused or not. And clearly, with some common surnames, etc., it's difficult to identify who that patient may have been. The hospital records, going back and doing name searches for someone who might have been in hospital at that time, have been destroyed by and large, so that's a problem. In terms of hospital discharge summaries that in days of old would have been in the old Lloyd George envelopes that took up lots of space in GP surgeries, those were summarised in preparation for digitisation in the mid-1990s. And so if we had a discharge summary of 3 pages summarising a complicated gallbladder operation to remove the gallbladder that went wrong and had multiple blood transfusions, if the patient came out the other side of that, that large discharge summary would be summarised as cholecystectomy, which is a surgical term for gallbladder removal, and any other details about blood transfusion, etc., will have been lost in that digitisation. So that's one of the problems. More recently, we have been audited, so there's been national guidance that any blood transfusion carried out in hospital should appear in discharge summaries. We've audited that across Scotland, and at the moment we get about 50% of blood transfusions recorded in a discharge summary. So in terms of trying to find those patients, you can see that we sort of progressively miss people. Assuming there are relatively few left, the transfusion booklets are no use to us, the discharge summaries have been lost from hospital records back in that period of time because they've been culled, unless the patients have ongoing contact with the hospitals, in which case they're very likely to have been tested. The GP records are lost to us now, and we don't have that option. And if the rate of recording of that data in the GP records or in the discharge summary is not very good now when it's mandated, we can only assume it was worse in the past.
And in terms of the elimination strategy going forwards, what measures do you understand local health boards to be taking to identify people who are infected with hepatitis C generally that might also pick up those who've been infected by blood or blood products?
So the risk factors that were identified will still be there and are still operating since 2009, and that message is being re-emphasised. There is a move across Scotland for the earlier diagnosis of liver disease in general, and we are, the process of a device called intelligent liver function testing, where if blood is sent to the lab for liver function tests, if they are abnormal, a whole gamut of tests are performed to arrive at a diagnosis for the liver disease. And amongst those tests are hepatitis C and hepatitis B. That's now government policy. Clearly the rollout has been held back by COVID. It is active in the 2 health boards, which I think I mentioned before, and is being rolled out across the country. So that would help detect those patients who have their risk factor for hepatitis C is lost in the past and are of advancing years, and you can find patients that way. In Tayside, we've now put 21,000 patients through that process in the years that the service has been running, and we found 142 hepatitis C positive antibodies. To my recollection, none of them are transfusion related, and all of them have other risk factors or are idiopathic.
As I did with Professor Foster, is one other matter in your statement I've been asked to address with you. Mm-hmm. You address in your statement palliative care and say that the viral hepatitis contribution to the group of patients requiring palliative care is very small. Can you explain for us what you meant by that?
Okay. Palliative care in liver disease is an emerging need. Hepatologists have been rather focused on saving everybody and resurrecting everybody from their liver failure because that's our background. We are now becoming increasingly aware of a group of patients in whom we can't achieve cure and survival, and they are not suitable for transplantation, and so we need to be more focused on their symptomatology. Palliative care medicine is also changing and moving away from patients who will inevitably die of cancer to looking at symptom control in a broader group of patients. And liver disease is one of those areas where there's a high mortality and lots of symptoms that can be controlled. So that's the need around liver disease as a whole, and that's a growing area of need. There are emerging professional consensus as to what should be done. At the moment, there's no government funding to support that. Within that group of patients, it depends on the etiology of the liver disease. If you can't change the projection or the trajectory of the liver disease because you can't change the underlying cause, then the patients will inevitably get worse. In viral hepatitis, both hepatitis C and hepatitis B, treatment will change that trajectory for most patients, and so their liver will recover and regenerate. And so if we were making the case for palliative care and the needs for it, the hepatitis C group of patients contributes less to that overall need because they have the option for cure. As we've seen, for instance, in the numbers of patients being transplanted for hepatitis C, which has from in 2011 and 2012, we were predicting that our entire transplant program in Scotland, the UK, would be overwhelmed by hepatitis C, and we would be transplanting nothing but hepatitis C. I think most transplant units can't remember the last time they transplanted someone for hepatitis C-induced liver failure. There is still an ongoing need for hepatocellular carcinoma transplantation. There is still a need for palliative care around those long-term hepatocellular carcinomas, but there is emerging evidence that the risk of hepatocellular carcinoma falls over time after cure. It probably never goes back to population normal, but the risk isn't as high as when you have active infection. And that's my reason for saying that the driving force for palliative care is not viral hepatitis alone, it's the generality of liver disease.
The inquiry's heard evidence from the palliative care panel that from their experience it wasn't a historical thing. One of the experts indicated this is seeing patients within the last few weeks of my practice who are presenting with advanced liver disease from blood transfusions years ago. It's still an active issue, and these issues are still very live. Does that then not accord with your experience?
So if you'd come to my ward 5 years ago, 6 years ago, half my liver patients would have had hepatitis C. The only patients we have in who have had previous hepatitis C are now in because of hepatocellular carcinoma, and that's a small number. So there has been a dramatic change in the complexion of the people that we're seeing in liver failure on the wards. And I think it's important to differentiate those patients who have active viremia and those who had hepatitis C and have an additional risk factor that's driving their liver disease, be non-alcoholic fatty liver disease or alcohol-related liver disease, that the two together are acting synergistically to drive things forward. So the previous damage from the hepatitis C has fertilised the field, if you like, and then the additional of another liver disease drives them through faster.
And so you are seeing that element where there's a synergy between the previous hepatitis C, even though they're now in a sustained virological response, but the synergy of that previous issue and something else does drive the liver disease more rapidly.
Yes.
Thank you. Thank you. Dr. Healy, you are the blood-borne virus clinical lead for Wales.
Correct,
Right? Can you tell us what that role involves?
Yeah, so similar to my colleagues, it's my responsibility to look at the clinical side of hepatitis C management and hepatitis B management and elimination. So I help with strategy around testing and treatment across the health boards in Wales. I lead a network of clinicians across Wales, similarly to try and drive towards elimination. And I'm charged, I suppose, on a clinical basis to try and find as many patients and deliver treatment and cure to as many patients as possible.
Could we turn to RLIT 301821, please? This is a Welsh Health Circular from October 2017, and we can see its title, Attaining the WHO Targets for Eliminating Hepatitis B and C as a Significant Threat to Public Health. And if we go towards the bottom of the page, we can see it's been sent by the Chief Medical Officer for Wales. And if we just turn the page, Dr. Healy, I'm just going to take us through the document and then ask you about it. The WHO has announced a global health sector strategy on viral hepatitis, which sets out to eliminate hepatitis B and hepatitis C as significant public health threats by 2030. The WHO target is a 90% reduction in incidence and 65% reduction in mortality due to hepatitis B and C by 2030. Wales is signed up to this strategy. The Minister for Social Services and Public Health has been advised by the Welsh Viral Hepatitis Subgroup of the Liver Disease Implementation Group on what is required from the NHS and partners for Wales to achieve this target. Then if we could go down to the second half of the page. I'm writing to you to request that measures are put in place to reduce and ultimately prevent ongoing transmission of hepatitis C within Wales, identify individuals who are currently infected with hepatitis C, including those who have acquired hepatitis C outside the UK and are now resident in Wales, and test and treat individuals currently infected with hepatitis C who are actively engaged in behaviours likely to lead to further transmission. Then if we turn at the page, please, we see a heading, Identify individuals who are infected with hepatitis C, including those who have acquired hepatitis C outside the UK and are now resident. 2.1, individuals infected with hepatitis C who were not linked to care. There are a number of individuals who've been diagnosed with hepatitis C, but who, for a variety of different reasons, have never been linked to care or who have never received follow-up investigation or treatment. for example, if they were diagnosed before there was any treatment available, who now can be identified through searches of the laboratory data system. By the end of December 2017, Public Health Wales will have sufficient information collated from laboratory systems to identify these individuals and will notify general practitioners of affected patients registered with their practice. Just pausing there, what can you tell us about that process of identifying individuals who had a positive hepatitis C test but hadn't engaged with treatment?
Yeah, so that programme of work is ongoing. It was separated out into 2 phases. The patients identified, it's 5,000 there, but I think it was 8,000 in total with the final figure, vary in their risk in terms of having ongoing hepatitis C. So this has been established by a tool through our testing databases, our lab databases. So sometimes we can establish someone has active infection and hasn't been treated. Sometimes we can only establish that someone has been tested and it's not clear whether they've been treated or not. So they're in different categories of risk. In the first phase, 1,650 individuals were written to alert them of their potential risk. So that's the highest risk group in terms of having ongoing infection. We had 140 individuals, about 10% of individuals who responded to that, and 62 who completed treatment as a consequence. Phase 2 was interrupted by the COVID pandemic, and we're now just in the process of starting phase 2. Of those remaining 90% that didn't respond to a letter, their details, along with details of other patients on that list, will be passed to the bloodborne virus teams across Wales, and it will be the responsibility of those teams to cross-check against patients that have been treated. So some of these individuals will have actually been successfully treated and they're just not linked up on the database, to actively try to contact them to bring them back to service. But also to flag them so that if they make contact with services for other reasons, that the issue of hepatitis C can be picked up. When we wrote to the GPs to alert them of the patients involved, we also asked them for them to be flagged on the system for that reason as well, so that they could be picked up in that way.
And again, this may be something you can't assist us with, but do you have any sense of the numbers of those patients who simply couldn't be tracked because records aren't there, their address is wrong, someone's changed their name, those sorts of issues?
I could get figures on that, but of the 1,650 that we wrote to, they will have been matched across the, I think it's called the Welsh Demographic Service, so they have been matched and they have addresses that could be written to. So those 1,650 are the ones that we know we can contact. But there will be some that aren't contactable for sure.
And in terms of those who are not the 1,650, what's happening for those other individuals?
Yeah, so that's part of phase 2, where we're trying to match them up with local teams to see if some have been contacted. They don't always contain the full data set, for example. So if they don't have an NHS number or they don't have a full demographic, sometimes there might be spelling mistakes within the system, etc., etc. And they can only really be overcome by individuals looking at them and sort of intelligently working them through.
And that will be the responsibility of the bloodborne virus teams within the region you think the person is, to then try and actually track down the correct individual.
Yes, exactly. Yeah.
If we continue reading the document, we see 2.2, identifying individuals who are infected with hepatitis C who've never been tested and are unaware of their infection. Hepatitis C testing on the basis of risk exposure rather than clinical diagnosis of symptomatic presentation is currently available via substance misuse services, GUM services, prisons and in some primary care settings throughout Wales. Despite efforts over the last decade to improve the coverage of testing, diagnostic rates remain low, and many individuals who are hepatitis C positive are unaware of their status. Testing needs to be increased in all of the above settings, and health boards will want to consider whether there is merit in adopting opt-out testing in substance misuse services. As a minimum, commissioners of these services should include a requirement to adhere to the existing annual testing offer for those accessing these services. There's then discussion in relation to other services in relation to high prevalence populations. And then all health boards should consider which populations are most at risk in their area and work with substance misuse area planning boards and services, third sector agencies, bloodborne virus leads and bloodborne virus nurses to implement effective testing strategies. The Welsh Viral Hepatitis Subgroup of the Liver Disease Implementation Group is currently undertaking a number of pilots in different community settings and will share strategies which are effective. In terms of those broader measures of identifying those who don't know that they're infected, first of all, who has responsibility for implementing these measures in Wales?
It's the health boards and the area planning boards.
And so where does the funding come from to address any initiatives that they might want to pursue?
That has to come from the individual health boards and the area planning boards.
So is it right that there's no central ring-fenced funding for elimination?
That's correct, yeah.
In your statement, you've talked about 2 other locations that funding can be obtained from. Firstly, the Liver Disease Implementation Group. What can you tell us about the funding that group can provide, has access to?
Yeah, so the Liver Disease Implementation Group has a budget of 1 million per year. It's only ever been available on a yearly basis, so it's never been clear whether there would be another programme the following year, which means any money that was available had to be spent within that financial year. And from that money, we have funded a number of posts which are in the report to help with elimination. So I received 1 session as bloodborne virus lead. We have a national pharmacy post, a national project lead.
So just to be clear, you have 1 session a week as the clinical lead on this, and 1 session is just half a day.
Half a day, correct, yeah.
And in terms of the funding only being available a year at a time, what impact does that have on the strategies that you could hope to pursue?
It significantly limits what you're able to achieve because, in general, you find out that funding is available around about the beginning of the financial year. So any strategies that you have that you might want to implement, they then require being worked up into a business case. So you lose a lot of time just in the preparation. So in reality, you're only able to fund things that might run for 6 months, maybe even shorter, and it's very difficult to plan over the longer term.
And would that also have an impact on the staff who you could employ, because their posts would only be secure for a year?
Yeah, so staffing you tend to employ on a secondment basis. Although I should point out that, as we discussed at the beginning, the responsibility lies with the health board and the area planning board, so longer term appointments could be applied for through those routes. Yeah.
You've also indicated that some funding is available through the Public Health Wales Communicable Disease Surveillance Centre, or at least they can assist with the strategy. What's their role in the elimination strategy?
It's the latter. They support through programmes of work and within their budget. So similar to the health board being responsible for delivering elimination locally, Public Health Wales assist through their programmes of work.
And I think you've indicated that that's primarily through epidemiological support or data analysis and coordination support.
Correct.
A strategy based on long-term central funding was proposed in 2015-2016 by the Health, Social Care and Sport Committee of the Welsh Government. But the Welsh Government report in response did not pursue that, is that right?
That's correct, yeah.
Could we just turn to that so that those watching are aware of it. RLIT 301822. We have a written response by the Welsh Government to the report on progress towards achieving hepatitis C elimination in Wales. And if we turn the page, we see recommendation 1. We recommend, so that's the committee recommendation, that the Welsh Government produces a comprehensive national elimination strategy for hepatitis C with clear, ambitious targets and workforce planning built in, and provides sustainable funding until elimination is achieved. This must be done as a matter of urgency, given that the current plan will end in that year, and funding for dedicated posts is only confirmed until 2021. And we see the response as accept in principle, but then if we go down to the bottom of the page, we see in bold financial implications, none, delivering the local actions required to achieve elimination of hepatitis B and C as a public health threat will be absorbed from within existing programme budgets and NHS allocations. So is that right? There was the proposal that there would be sustainable central funding, and the response was it would be dealt with locally.
Yeah, I think that's correct. So I think their position was that they didn't have central funding for other disease targets, cancer, etc., and that it was devolved to health boards, and they were taking a consistent approach, I suppose.
And we see a similar point in recommendation 2 over the page. The recommendation was for us, the strategy must include a targeted awareness raising campaign to reach out to at-risk communities and also provide for education and training for health professionals, accept in principle, but then in relation to financial implications, none, delivering the local actions required to achieve elimination will be absorbed from within existing programme budgets and NHS allocations. In terms of the strategies taken by local health boards, what can you tell us about what has been done by local health boards?
Yeah, so similar to what's happened in England when Professor Foster was talking at the beginning, right back in the beginning when the DAAs became available, the directly acting antiviral agents became available, we had a number of people in care who needed treatment, and the treatment was allocated to those individuals on the basis of clinical need, and that backlog was cleared within 2 years. So I think it was 2014 was year one. So by 2016 we had cleared the backlog of patients that needed treatment. There was some anxieties, as you pointed out earlier, about people having to wait, but the wait for individuals who had mild liver disease was much shorter than anticipated, and we didn't see that really as a significant clinical problem. And we worked as a network to ensure that there was equitable and transparent access to care across the country, so there was no postcode prescribing. Everybody was treated at the same rate at the same time. We worked with our haematology and consultants and teams looking after haemophilia patients to make sure that they were reviewed, so that any were referred, any that wanted to be referred were referred to care, and the new treatment options were discussed with them. Subsequent to that, in phase 2, we have focused a lot on the population where there's ongoing risk of active transmission and where we have our highest prevalence, so through substance misuse services, people who inject drugs. We've developed key performance indicators for those services, which were due to start in 2019, again have been disrupted by the pandemic. So the target for this year is the same as 2019's target, which is 50%, with an anticipation increase to 90% from next year. Treatment's freely available. clinicians are free to choose whichever medication they feel is most appropriate for the patient that they're seeing. And we've done educational events across the country to inform primary care, other services about the change in treatment that's available to encourage referral through to service. We have done a number of different projects. So Professor Foster was talking about the GP program, which can pick out people with risk factors for hepatitis C. So we did trial that in North Wales some time ago. We didn't find it as successful as we might have hoped. We're watching very carefully what's happening in England, and we have been talking recently about whether that is something that we might try again, because I understand it's been quite refined since we first used it.
Just pausing there, can you tell us what the problem was when you first used the tool?
Identifying a very large number of individuals, many of whom weren't at risk, and then not getting very much in terms of pull-through from primary care in relation to those number of patients identified.
So when you say pull-through from primary care, what do you mean by that?
So we might identify a large list of people who might have a risk factor. Difficult then to know exactly what that risk factor is, and then not many of them accessing testing, and then not many of them ending up in treatment.
And you talked a moment ago about doing some sort of awareness raising with primary care colleagues about the new treatments. What can you tell us of what that involved?
So that will have been done locally in each health board. I'm also the lead for hepatitis in Cardiff, so all primary care physicians have to go to training days, and they're split so that the practices are still active. Yeah, so in order to cover all of the primary care practitioners in Cardiff, you have to do 2 events. So we've done that on two separate occasions to raise the issue of hepatitis specifically with our primary care colleagues. Yeah.
And have there been any measures taken specifically to try to identify those who've been infected through blood or blood products?
Not out with those 2 programs that I mentioned. So we anticipate that a significant number of people who would have been infected through blood or blood products will have been diagnosed previously. So the program of work trying to find people who have been diagnosed but not linked to care will capture them. The primary care looking for people with liver disease was an attempt to try and capture those individuals suffering from the same problems that we've heard from my 2 colleagues in terms of what data is held in primary care and records dating back that far in relation to blood transfusion. So that was an attempt to do that, but like I say, because of its lack of success, we've paused on that. Yeah.
You talk in your statement about a number of places that testing is available in the community. You've highlighted it being available through substance misuse services, criminal justice services, prisons and homeless services, as well as primary and secondary care. And you've said that testing in pharmacies is under development. What can you tell us about that?
So, because we have a rural community, we know that a significant number of our at-risk population, people who inject drugs, only access needle exchange and opiate substitution therapy through pharmacy. So it's a key part of our strategy that testing is available in those settings. We have found it difficult to get traction in terms of numbers of individuals being tested. So we're continuing to work on that. We're not giving up on that strategy because it's such a key element of delivering elimination because of the rural nature of Wales and the fact that such a significant proportion of people only access care that way.
And do you think, I've been asked to ask, that do you think that having to attend somewhere like a substance misuse centre might put people off attending for testing, particularly if they think they've been infected through blood or blood products? And what do you then see as the benefits of the pharmacy provision?
Yeah, so pharmacy provision is specifically targeting that group. We wouldn't expect to capture people who've been infected through other routes through that programme of work. Testing is widely available, primary care. Anyone should be able to access testing in Wales in a relatively straightforward fashion. We have also been looking at the programme of work that's going on in England around postal testing, and that's something that we're also keen to develop. We want to make testing as freely available and as tailored to the individual as we possibly can, but that work is also in its infancy.
So just to be clear, the pharmacy testing is connected with needle exchange. It's not a general provision where somebody could think that they wanted to be tested and go in and be tested.
Correct, yeah.
Okay. And so somebody who thought they might have been infected through blood and blood products would have to go to their GP to access testing.
Yeah.
Thank you. Dr. McLean, can you see and hear me?
Yes, I can. Thank you, Sarah.
You are the Director of Public Health in the Public Health Agency in Northern Ireland, is that right?
That's correct. I've been the Director of Public Health in the Public Health Agency since the 1st of September this year, so relatively new in post. And in that role, I have responsibility for ensuring that the agency discharges all its statutory public health functions. So those relating to infectious diseases are one area, but I'm also responsible for public health input to service development, to screening and to wider health improvement activity.
And the Hepatitis C Elimination Plan Phase 1 was published in January 2021, so before you became Director. But what can you tell us of the focus of that plan? What's the focus been?
So, as you say, it was published in January 2021, and it is very much focused on people who have acquired hepatitis C through injecting drugs. That is, by some distance, our biggest group of new infections, and it's a particularly challenging group to target and to engage with services to ensure the people receive treatment. So for that reason, because it is our biggest epidemiological group, the focus has been on that group to date.
And if we turn to RLIT 301696, please, Lawrence. We see the elimination plan, and if we turn to page 8, we see the heading Priority Populations, and it's the second paragraph. Over 2/3 of those treated for hepatitis C infection in Northern Ireland have a history of injecting drug use. And then it continues, this population is a priority in terms of the clear burden of experiencing hepatitis C infection. Within this population, priority risk factors include homelessness, addictions, and admission to prison. And then it says other populations include people who were infected with blood products, healthcare staff with needle stick injuries, etc.
Yeah.
You've indicated in your statement that there are no specific actions relating to those who were infected with blood and blood products within the elimination plan. Can you help us with why that is?
So I think it is because the focus in this plan, which is very much the first phase of the elimination plan, was to focus on that larger group, and also to focus on this group which are challenged to engage with services. So quite often it can be hard to reach this group, to get them to go for testing and to get them to engage with treatment services. So I think it was felt that particular effort was required around that group. Having said that, another of the actions in the elimination plan was that hepatitis C was made a notifiable disease in Northern Ireland, and that happened in the summer of last year. So that's a relatively new thing. The important thing from a public health point of view about that is that every time someone is now diagnosed with hepatitis C, it's mandatory that the laboratory tells us in public health, and that then allows us to work with the clinicians involved and work with the people looking after the patients and the patients themselves to identify their risk factors, do contact tracing, and really find out more about where they have acquired their hepatitis C. Now, my understanding is that since the elimination plan has been published, the information that we have received is that we have not had a new diagnosis of hepatitis C associated with historic use of blood transfusion and blood products in Northern Ireland. But the introduction of hepatitis C as notifiable disease does allow us to systematically start to gather information about that in a way which we couldn't in the past.
And so in terms of making hepatitis C a notifiable disease, you've indicated it allows the tracking of how many people are being diagnosed whose risk factor relates to blood and blood products.
That's correct, yes.
But Dr. McLean, would it also allow for any tracing backwards if someone has also been a blood donor?
So I think that would be something that the clinical team and the Northern Ireland Blood Transfusion Service would be better able to answer. I can find more information about that and provide you a further detail on that. But if someone has been a blood donor, that would be a question for those services to investigate. But I can provide more information.
I think what I was asking you, Dr. McLean, was whether you were aware of any linking up between the notification of the disease and the transfusion service.
So at the minute, I'm not.
The notifiable disease point is one aspect of the actions that have been taken in relation to what you've termed the priority population. Are there any other actions that have been taken relating to the priority population that you think would still impact on identifying and engaging with those infected through blood and blood products?
So we have, and for a number of years, have highlighted or run information things around hepatitis awareness. So, for example, on World Hepatitis Day, the Public Health Agency would disseminate particularly social media posts and videos and information, and they will remind people or inform people about the risk factors for hepatitis B and C more generally. And one of those risk factors that the media content includes is highlighting people who have received blood products and blood transfusions in the 90 primarily before 1981 and 86.
Could I turn you then to WITN 7311004, please? I'm sorry, Dr. McLean, I've just seen on the transcript that you referred to blood transfusions primarily being before 1981. Did you mean 1991?
Yes, sorry, 1991. Apologies.
I'm not sure if it was a transmission issue or an error, but we just want to make sure that the transcript is correct. WITN 7311004. Thank you, Lawrence. This is the Northern Irish Regional Hepatitis B and C Managed Clinical Network Annual Report 2020. Before we look at the content of it, could you tell us, first of all, what the network is and what its purpose is?
So the network is a collaboration of clinicians and from across Northern Ireland, those working in the Regional Hepatology Centre who will be responsible for treating all our patients with hepatitis B and C, along with people in local trusts, with people who work in other areas, for example, prisons, drug services, things like that. So it's bringing everyone together along with service commissioners and the Public Health Agency to try to put in place the best possible treatments for patients with hepatitis B and C.
And if we turn to page 10, there is a table setting out the route of hepatitis C transmission recorded by patients presenting for treatment in Northern Ireland 2000 to 2020. And we can see that in relation to blood and blood products, the number is 128 out of a total of 1,696. So a percentage of about 7.55%. Would it be fair then that from this table, it seems that there are still a reasonable number of people being identified as infected with hepatitis C from blood and blood products?
So that table relates to people who were diagnosed over the past 20 years. So the bulk of the people who are in that group for the blood and blood products group, I imagine will have been diagnosed the earlier part of the time frame, so in the early 2000s rather than in more recent years. And I think that number, whenever you look at it compared to the numbers in the statistical report, makes me think that we have identified certainly a large proportion of people in Northern Ireland who were identified or who were infected through blood and blood products.
And then if we turn the page, we see the heading Hepatitis C Patient Re-engagement, and I'm just going to read it out for those listening and then ask you about it, Dr. McLean. The Liver Clinic has an extensive database of patients known to have hepatitis C infection, and in February 2019 it started using the database to try to reconnect with those with whom we had lost contact. A callback process was started to trace and treat patients who were previously diagnosed as having a chronic active infection and referred, but who never attended clinic. Several of these patients were identified, contacted and offered testing to confirm whether they still had an active infection, and then invited to clinic to be assessed for the newer, more effective treatments. Of those identified and contactable, only 7% came forward for specialist assessment and treatment and have since cleared the virus. The rest of those individuals identified were either uncontactable, refusing to engage, no longer living in Northern Ireland, or had died. All those who were uncontactable or who did not attend appointments during the callback process will be sent follow-up letters, and the outcomes of this will be reported on at a later stage during 2020. In terms of the database of patients who were being reconnected with, would this include those who had contracted hepatitis C through blood and blood products and had a previous positive test, but who'd then not engaged with treatment or not felt able to carry on?
So the database is held by the clinical service, so it's held in the Belfast Trust by the hepatology unit. So it will be anyone who they have engaged with in the past who have had a positive treatment and they've had contact with, irrespective of how they contracted their hepatitis C.
In terms of in terms of the specific group of people who have been infected with blood and blood products who potentially have not yet been identified, you said in your statement that you anticipate that actions will be set in relation to that group in phase 2 of the plan. Do you have any understanding of what those actions are likely to be?
So I think that we are open to constantly reviewing our plan and our actions. And I've listened with interest and read the statements, particularly from England, around the efforts that they have made to further reach out to this group of patients. And I think it would be very helpful for us to take the learning from the various projects underway in England to see, is there a way that we can refine testing, refine targeting of patients to try to identify any remaining patients who may be undiagnosed in the population.
I want to then move to some more general questions to all of you as a panel. And first of all, if I can start with thinking about the English case finding search tool and the Bristol study. In terms of Dr. McLean, Professor Dillon, Dr. Healy, what are your perspectives on whether a similar exercise would be helpful in Scotland, Wales or Northern Ireland?
I think our intention is to wait and see what happens from the England perspective and the report on it. Separate to that, we are working on some epidemiology work to try and better identify what the prevalence is within Wales. And an epidemiology colleague is looking at carrying out a I forget the term actually, but it's looking at all different risk groups essentially, and trying to get testing carried out in various risk groups, pooling that together, multiplying it up to get an overall idea of prevalence, which would capture some of what you're trying to ascertain. And I think that project hasn't been definitely funded, but we're working on that. And if that's funded, we'd put that together with what they gather in England and then devise a strategy on the back of that.
From a Scottish perspective, we'll see what our English counterparts come up with. We have an ongoing project, again working with Professor Hickman's group in Bristol, looking at the epidemiology and the changing epidemiology of hep C infection in Scotland, and that is due to report in another 2 years' time. So we'll have more data from that in terms of the ongoing risk of transmission and whether that's falling. The early cuts of that data suggest that the rate is falling and there are not hidden pools of transmission and so things are coming to an end, and we're not seeing, with our record linkage, a huge surge of patients presenting late with liver disease related to hepatitis C that was transfusion related.
Dr. McLean, do you want to add anything from a Northern Irish perspective?
Just to say, we'll also wait and see what the English work shows us and if we've any learning for us.
All four of you have mentioned the impact of COVID on the ability to address and progress the elimination strategies. Post-COVID, do you have any concerns about whether hepatitis C will be given priority in terms of resources and focus?
If I start from the English perspective, we've no suggestion that the pace within the elimination programme will falter. We're looking ahead to the next year at similar levels of funding. The procurement contract with pharma finishes in 12 months' time, and we're already starting discussions about extending into a slightly different model. So certainly in England, there's no suggestion that we're taking our foot off the gas. A lot of it will be driven by the data that comes forward, how much left to do, but there's very much a commitment from a very high level to finish the job we started.
I think the decision is yet to be made in Scotland. We got stopped as we were starting. The teams were largely broken up and redistributed to COVID. Very few of us were still doing any hepatitis C work during that time. The epidemiological data is due to appear, as I said, later this month, and the civil servants that are part of the committees that will be reviewing that will be reporting to ministers. It would need a new pharma contract. It would need ongoing commitment to a very substantial increase. Having lost 2.5 years of progress, it's now looking at delivering 6,000 or 7,000 patients into treatment a year as opposed to 3,000 patients a year to achieve elimination, which is a very tall order. So I suspect that a delay to the elimination date might be the most likely outcome, but we'll see what's happened to the epidemiological data over the years of COVID, whether there has been ongoing transmission or whether the transmission has fallen during the lockdown is one of the unknowns at the moment. We're looking forward to seeing that data.
You obviously have concerns about whether you'd reach your elimination target, but in terms of funding and staffing, is there any concern about returning to pre-COVID levels of your teams?
I think there is concern about that. Lots of people have been redeployed and haven't come back. The teams in Scotland weren't people who are focused solely on hepatitis C. They continued a number of other functions through needle exchanges, community pharmacies, etc. The way addiction services have been organised has changed dramatically during COVID, and whether they will return to the pathways that we had before, I think that's unlikely. They will be different, and so we'll need to start building those relationships all over again to encourage people who are involved with the populations who are injecting or have injected drugs in the past, and getting them back in sync with the hepatitis C elimination programme will be a new challenge to go forward with.
Dr. McLean?
I think that our elimination plan being published when it was a big challenge because it was right in the middle of COVID. It is only now that we're starting to bring our teams back and get key staff in post to be able to deliver this. So I do think that while it's been challenging, at least we are now in a position where we're able to move forward and we have resources for key posts related to this.
Dr. Healy?
On Tuesday, I attended the first meeting of the Elimination Oversight Group, which has a number of key individuals at key posts in Welsh Government and health boards. So there's definitely an appetite to move forward with elimination. However, at the same time, I'm very conscious that we're pitching for funding in a very resource-limited area. And so I think I'm hopeful, but I'm also realistic, and time will tell a little bit in terms of where we get to.
And in terms of those sort of structural and coordination elements you've talked about, the issue of engaging with primary care colleagues has been raised by all of you. Why do you think it's difficult to engage with primary care colleagues? What are the challenges that you're facing?
The GP workforce has fallen in terms of numbers of doctors. The demand has gone up, and it's another straw on the camel's back. And to expect them to deliver more from a diminishing resources a struggle. So that's part of the. I think, and I don't see an imminent solution to that in terms of recruitment into general practice, training new general practitioners, etc. It's an ageing workforce. Large numbers of them have retired in the last year or are on the verge of retiring, and that makes it an increasingly difficult group to deal with. I think they've equally had, COVID has been difficult for everybody, but I think the general practitioners probably had a disproportionate impact on the workload and less resilience, and that has added to the problems. And I think the general appetite amongst them for taking on something new and different is pretty low at the moment.
Do others have any thoughts that they want to add to that?
I strongly agree with John. It's an increasing demand on a fragile, limited and reducing workforce. So it will be difficult with public expectations of primary care seem to have risen dramatically, and at the same time when the capacity to deliver those has been reduced. So it will be a significant challenge.
The English idea of GP champions was raised. Do any of you have any views of what could be done to improve engagement with primary care colleagues?
To be honest, we've probably moved away from using general practice as the major delivery workforce for this, and we will be looking to third sector partners and nurse-led and peer-led initiatives to deliver the majority of treatment, and decentralising prescription away from medics into other partners in healthcare is the direction of travel in Scotland. And so we don't anticipate general practice having to play a large role in delivering elimination in Scotland.
Yeah, I agree with that. We've decentralised. We're using different models of care to try and engage. I suppose central to the question you're asking is how do we engage primary care in trying to ensure that there are no missed individuals from who may have received blood products in the past. They definitely need help in that regard, and hopefully the programme of work that they're doing in England in terms of identifying at-risk people will help. How we then encourage those individuals to get tested is a challenge, isn't it? I think, yeah.
Dr. McLean, do you have anything you want to add to that?
No, I would concur that for general practice is such a huge workload.
And in terms of, Professor Dillon, you've indicated you're sort of moving away from using GPs too much, but in terms of that awareness and education element, so that if a patient presents with saying, I think I've been infected, or with a raised ALT and testing is needed, what could be done to assist GPs to be more aware of hepatitis C and the need to test?
So I think from presenting with symptoms of tiredness and fatigue and abnormal liver function tests, decision support tools such as intelligent liver function testing, which is now part of the clinical diagnostic centres policy in England and is also policy in Scotland, will help, because then the testing becomes automated so that it doesn't require a specific thought about hepatitis C. It's part of the whole panel is tested on those abnormal test patients, and using the appropriate normal ranges for ALT will find those patients that have previously been missed by using ALT strategies before, which were at a normal range that was too high. And so we will find those patients. But as we've seen from the statistical estimates of how many people there are. We are dealing with a small number of patients, unless those statistical estimates are wildly inaccurate, which with the thoroughness they've been done seems unlikely.
Do any of the rest of the panel want to add anything?
No.
No. In terms of other steps that might be taken to identify individuals, do you think a public awareness campaign should be commissioned about the risks of hepatitis C from blood and blood products?
From the English perspective, we've looked at this very carefully, considered it, and at this stage we don't think we have enough information to guide us there. I think at some point a public information campaign for hepatitis C and bloodborne viruses might be very useful, but I'm not sure where I would target that at the moment. Are we targeting people who used drugs 20, 30 years ago? Are we targeting immigrant communities? Are we targeting people who gave birth in 20, 30 years ago? So I think until we have information about where we would want to target that, I wouldn't want to advocate it. Essentially, you get one shot at a public health campaign, so you've really got to get the targeting right, and I'm not sure we have. And I think we'd want to look at a public health campaign for blood and blood product recipients in a very targeted fashion. It may be better, for example, to say if you have a 20-year-old child, you need to be tested for hepatitis, and we might be able to do that by a more effective way than a public awareness campaign. So I'm not yet convinced, but I think we would certainly be attuned to the idea if it was shown to be valuable.
I'm not best placed to answer that question because that's not my expertise, but we have discussed it within Wales over the years, and people who know a lot more about this than I do have pointed out that people tend to remember the very successful public health campaigns, but they don't remember the unsuccessful public health campaigns. And there is a degree of anxiety around launching an unsuccessful public health campaign with all, which is costly and money that might have been better spent elsewhere. So I'd agree with Professor Foster in terms of if we are going to launch one, then we need to make sure we get it right, because you only get one chance.
In Scotland, we did it a decade ago. It wasn't terribly successful. There's no appreciable increase in the numbers of patients diagnosed. It was focused across the whole spectrum of possible risk factors and encouraged people to access testing. There was a corresponding awareness raising campaign amongst primary care colleagues, so they were ready to expect it, and we didn't notice an impact from it at all, despite spending, I think, upwards of £7.5 million on it.
Dr. McLean, you're nodding. Is there anything you want to add?
Yeah, I think it's really important that we remember that public health information campaigns cost a lot of money, and we need to make sure that they're targeted appropriately and that we know what we want to get out of them. So I would echo what others have said.
And what are your views of whether a wide-scale hepatitis C screening programme of the public should be undertaken, perhaps for those over a certain age, or perhaps for women who've got or who've given birth at a particular time frame? What are your views of something like that?
I think, again, almost refer to, let's see what the data shows. If the data shows that that would be helpful, and if people over the age of 50, between 50 and 70 are coming up in all of our testing, then that would be a good thing to do. But I tend, I'm afraid, to follow John's approach in Scotland, which is we should be focusing on liver health, and hepatitis C is a part of that. Hepatitis C is a minority cause of abnormal liver function tests nowadays. If we go for abnormal liver function tests, we may get better buy-in from primary care physicians. We'll certainly get a lot bigger hit. We'll find a lot of people with manageable disease, and in so doing, we'll also pick up any remaining hepatitis C. So I would, at the moment with the data we have, be advocating a abnormal LFT pathway rather than a hep C pathway, but we'd be very sensitive to data and we'll change if necessary.
I would agree with Professor Foster. It's always nice when he takes one of my ideas. But I think in terms of the health economic arguments, if we were to set up a screening programme or a case-finding programme, it would be more cost-effective to look at the broader health implications of liver disease in general rather than hepatitis C specifically, and that would it would be an easier argument to win in terms of the allocation of resources, because it wouldn't cost much more to look across the whole spectrum of liver disease rather than just focusing on viral hepatitis.
And I think that you get better buy-in from GPs.
Absolutely.
Comes back to Professor Foster's earlier comment that if you have people doing lots of tests and never finding it positive, people lose faith in any form of screening program. And so if we were to broaden it across liver disease, you would find liver disease, it's about 3 to 4% of the population have significant occult liver disease that requires some form of intervention. And so amongst that, it will be the hepatitis C's and hepatitis B's.
Just one thing to add, whenever you're doing any screening program, you have to consider the potential harms that might come from a screening program. So I think people tend to think relatively simplistically, in so much as if we screen, we'll find people with the infection and we'll treat them. But you have to take account of the fact that some false positive tests will occur, and any screening program around liver disease, you'll get false positive tests around whatever test you employ. So they do have to be carefully considered. It's not quite as simple as it first sounds.
Does anyone want to add anything else to the discussion?
I think I would add that for any population screening campaign, we would want to carefully consider by the National Screening Committee. We have a range of population screening programmes in the UK, all of which are considered carefully by that committee because, as others have said, there are harms. And as well as that, if we headed out and identified lots of people who might have a condition, we then have to have the services in place to actually assess and diagnose them. So really important that any decisions were taken through the National Screening Committee in this.
As a different thought in terms of identifying people, in Wales there's obviously the pharmacy testing, but only in relation to needle exchange. What are your views of whether extensive provision of hepatitis C testing should be available at that community level for anybody attending a community pharmacy?
In England, we found it very difficult to engage with pharmacies, and we're very envious of the success that our Scottish colleagues have had. And a lot of that is related to the workload in pharmacies. They're busy. The yield in terms of hepatitis C test positives has been relatively low, so they haven't been terribly well reimbursed. There is a fear, I think a perhaps overblown fear, that if we were to say to pharmacists, we'll pay you £15 for testing anyone who might have hepatitis C, a smart community pharmacist would put a very junior individual at the door and test thousands of people a day to very little gain. So I think we would want to look very carefully at what the added value would be of community testing in pharmacy. We do want more testing, but it does need to be appropriate testing. And I think it's striking that balance between spending a lot of money testing a lot of people. And I think the comments from Dr. Healy were entirely apposite, that testing everyone does yield false positives, and they become very distressing to all involved. We're just dealing with, we've done a 10,000 patient survey in addiction services, and I have 2 false positive HIV tests. And those people are very distressed by that. So there is a cost to a test, and no matter how good the test, when you test a large number of people, you will find some, and that will cause harm.
Any other views?
In Scotland, in Tayside, my part of Scotland, we've had good success using community pharmacies with testing focused on needle exchange and opiate substitution therapy recipients. We are in the process of negotiating a national pharmacy contract around doing that for the whole of Scotland. It's become part of a more generalised contract which has been bogged down a little recently, and so those negotiations are ongoing.
But what would your view be of extending that to perhaps a particular age group who would be able to walk into a community pharmacy and request testing?
I think for the general population, if they don't have a particular risk factor, we would find more false positives than we'd find true positives. So I think would be a risk because the population prevalence outside those with an overt risk is very low. Now, if someone is particularly concerned and is going in to ask for a test, they probably think they have a risk factor, and therefore the pickup rate would be justified for that. So I think it would be that assessment of the risk factor before randomly. Because of the stigma associated with hepatitis C, a more anonymous testing route for those people who aren't still engaged in opiate therapy or injecting behaviours, then that facility might be a more neutral ground. Although the online options that Professor Foster has described earlier on might be a good option for that.
Yeah, and similarly, very keen to see barriers to testing lowered in appropriate populations. But as colleagues have alluded to, you protect against the harm of screening by making sure you're targeting an appropriate population with at least a decent prevalence to protect against the risk of false positives. So yes to reducing barriers, but we have to do it intelligently.
And so perhaps I think I'm hearing from Scotland and Wales and perhaps also Northern Ireland can indicate that, Dr. McLean, your views of the postal and the online portal giving access to postal testing might be more appropriate than wide-scale community pharmacy testing. Would that be your views?
I think it overcomes the barriers of stigma, etc. It makes it easier for people to make that choice that they wish to pursue a test, and I think that's a lot of attractions to it, rather than having to go and explain yourself to someone in a pharmacy as to why you want a test, which I think would be daunting for some people. So I think the online tests with a supportive advice from what I've seen of the portal in terms of appropriate testing might be the better way forward.
Dr. McLean, do you have any views on the online portal?
So I would agree with that, as long as it provides information and is targeted in some way, so that it doesn't become like a backdoor, random kind of testing process.
Yeah, it's the targeting, I think, which is key.
And finally, final issue. When considering how to avoid something like this happening again in terms of the infected blood situation, and in terms of the challenges that have been faced in tracing people who have received blood and blood products, it might be suggested that record keeping is important, and it might be suggested that there are matters in that regard that need to be addressed. Professor Dillon, you explain in your statement that compliance is suboptimal with the guidelines that recommend that transfusions are included in the discharge communications with GPs. Can I ask the panel broadly what your views are on that issue of communication from a hospital setting to a GP and record keeping that indicates someone has received a transfusion?
So I think that has now moved away from the ancient Clark books of times gone by, and blood transfusion services now have extensive records of who's received which unit of blood from whom, and indeed all of the blood products. So I think in terms of if there is a new infection or a new complication from blood transfusion that we need to think about going forward. For the last decade, 2 decades, we now have very sophisticated records that would allow us to identify exactly who received what and what their risk factors were. And so I think that's changed, and so we're not going to be going through GP records, and our hospital records was always the second best option, which we've had to use because there wasn't a best option. In terms of we didn't have sophisticated records for blood transfusion, which we now do. I mean, the health service had less sophisticated records previously. They are now better, and I think in terms of blood transfusion, we'd be able to trace those patients very effectively.
I've been asked to ask the panel whether any of you have any residual concerns about the current system of record keeping that would allow that tracing to take place. And it may be that you can't assist us on this question because it's not really your area.
I agree with John. I think that the system is so much better. I'm not an expert on data transfer and data linkage, but we do seem to have an awful lot of systems which talk very poorly to each other, and we have a lot of systematic barriers to data transfer. Data protection in the health service is something we treat very carefully, and perhaps too carefully, in that GP records often aren't available to treating doctors in hospitals and vice versa. So I think there is certainly work to be done linking up the data systems and having a more grown-up conversation about what data can be shared with which healthcare professional. And I think those conversations are beginning. But I think the systems are much, much better, but not perfect.
I'm not aware of any risks, but that question would be better directed towards the Welsh Blood Transfusion Service. But I also agree with Professor Foster that the risk in the future may not be related to blood transfusion. It's a much broader topic around record keeping in general and records being available. And there's definitely a lot more work that needs to be done within the NHS in relation to that as a whole.
Dr. McLean, I don't know if you have any views you want to add.
No, but just to concur and say that as we move towards electronic records that patients have access to as well, I think that will better inform patients about their own treatments as well.
So those are the questions I have for the panel. We obviously now need a break to allow recognised legal representatives to provide me with any further questions they would like me to ask the panel.
Well, you've timed it very nicely as we coincide with our usual break time for lunch.
It was entirely intentional, sir.
Very well. Well, let's say not before 2. I imagine the hour will give plenty of time for Ms. Fraser-Butlin to field any questions that core participants may have for you, which they will direct through their own lawyers to Ms. Fraser-Butlin. But just in case there are more, or for that matter, late coming in questions, we'll say not before 2. You'll be told if it's any later. I can't tell you quite how long you'll be detained after that, but it will be, I would hope, in plenty of time for your travel arrangements this evening.
Thank you.
2 o'clock. Not before 2 o'clock.